and change matters. These are my disclosures. So the reason that we use chemotherapy is this trial, you should all know this, which is the Vogelsang trial, which demonstrated compared to cisplatin alone, the combination of cisplatin plus pemetrexed did have a small but meaningful survival advantage, but really the efficacy data is not very good. Even with that, we're looking at a median of 13.3 months compared to 10 months, with about half the patients having some degree of tumour shrinkage. Now, is tumour shrinkage by CT criteria really tumour shrinkage? That's probably a talk for another day. But that's what we've got as our established standard of care, and that was back in 2003, and it's only in 2008-ish that pemetrexed really became available in the NHS. So since then, there are some solved questions with drug therapy. Should we be giving chemotherapy early or waiting for patients to deteriorate? We should give it early, and I'll tell you about that. Should we be giving everybody cisplatin if they're not fit for it, abandon chemo, or use a carboplatin? Well, carboplatin is certainly not a weaker platinum, and given the aging population we have, carboplatin is very good. And what should we do when our patients recur? And I would say we've got no proven benefit for any second-line chemotherapy, but I'm going to talk to you about where we're going in terms of drug development for that, because there's lots of action around the corner. So should we be giving chemo early or not? You know, you have all these patients, they present, they either have their surgery or not surgery, depending on your local practice, and they're over to the oncologist, and by the time they got to us, they've already seen 2 or 3 people, and they've already been indoctrinated with whether they should be having their chemotherapy early or not. Well, we've run the trial. This was run at the Marsden several years ago, small trial in the era before pemetrexed became available, and these patients all had mesothelioma, not operated, randomized to either immediate chemotherapy or not chemotherapy immediately and delay until symptom deterioration. It's a small study, but you can see that survival was improved in patients that got the immediate chemotherapy, and patients that were randomized to receive their late chemotherapy. A quarter of them actually weren't fit enough to receive any chemotherapy at all, and that's using a regime which was not particularly effective or even particularly toxic to patients. So should we be using cisplatin or carboplatin? Well, this one's already been nailed. When pemetrexed was made available, the company made it available in conjunction with cisplatin or carboplatin to investigators in what's called a European Expanded Access Programme. So you could either use pemetrexed by yourself if you wanted to, or in conjunction with cisplatin as per the clinical trial, or in combination with carboplatin if your patient was deemed unfit. You can see a slightly higher response rate for cisplatin versus carboplatin, but actually the survival is actually quite similar for the two. Now, given the fact we've got an aging population, cisplatin is next to impossible to administer in a patient in their late 70s. Really, carboplatin is a very, very reasonable option for these patients. So where are we going with drug strategies? This is a table from a recent publication about a variety of trials that are ongoing, and I'll just talk about them in principle. So you have your vascular disrupting agents, you have your inhibitors of cellular process, you have your metabolic inhibitors, and then you have immunotherapy. And I'll talk to you about why these might be important or not, as the case may be. Right, so what about targeting molecular aberrations? You know, you all sit on your lung MDT and your oncologist is prattling on about some mutation you've never heard of and getting excited about that. Well, actually, that's made a massive change to the way we treat our lung cancer patients. So we have our lung cancer patients, we can stratify them by molecular genotype, and actually we've got incredibly good effective therapy for our ALK patients, our EGFR patients, our ROS patients, our RET patients, and our BRAF patients. They might not be available on the NHS, but they exist. And in fact, the outcomes of these patients are almost as good as patients with metastatic breast cancer. These patients are surviving years. We've totally transformed the way we treat adenocarcinoma driven by a molecular biomarker. Now, can we do the same thing in mesothelioma? And I would suggest that we're probably well on the road to doing that. We've gained some very good insights about the way the biology, the carcinogenesis of mesothelioma developing. And one of the things that we've identified is this phenomenon here, NF2 loss, which is actually quite common. It's seen in about 40% of the mesotheliomas that we test. NF2, as you know, is mutated in familial schwannomatosis and neurofibromatosis. That's presumably where you guys come across most of the problems in your rare patients when you resect these, if at all. The NF2 protein is called Merlin, and if you've lost Merlin, what that does, it triggers a whole series of intracellular signaling pathways. The important thing here is that these intracellular signaling pathways can be treated quite effectively with compounds which are either already licensed, already in late development for other types of cancers, or are being specifically developed for lung cancer. So NF2 loss activates mTOR and PI3 kinase, so you have very effective drugs either against both of those pathways or individual pathways, very effective in breast cancer. It switches on FAK signaling. I have to be quite careful how I pronounce that in public. But there is a very good FAK kinase inhibitor which is being trialled in a maintenance setting. So after you've completed chemotherapy, you're randomized to the FAK inhibitor or not. It can trigger ERK signaling, and there are inhibitors of the MAP kinase signaling pathway, as well as Hippo and YAP signaling, and those compounds are in development as well. There's another a drug strategy which basically says, oh, I don't really care what the pathway is that it triggers, let's just switch off the abnormal proteins that are triggered. And you can switch off all of these non-specific proteins by targeting something called HSP90, and there's a drug which does that quite effectively. It's called gantenerumab. It's trialled in lung cancer at the moment, has some activity in lung cancer, and it's being trialled in mesothelioma at the moment as well. So there's a huge interest in looking at this cohort of patients with NF2 loss, and it wouldn't surprise me if in about 3 or 4 years' time we're sitting in the tumour board and saying, actually, have you done the NF2 test on your tumour yet? Because that will determine what sort of drug sensitivity we're going to be doing in these patients. Now, the other big news in mesothelioma is BAP1. Now, most people haven't really heard about BAP1. It's a bit of sort of hoi polloi, but actually this is quite important. So we know that there are some families, these are very rare families where mesothelioma occurs within families. So we know that these occur in families which have had exposure because of working issues, but there are families which present with mesothelioma and other cancers where there's no obvious environmental cause. So there's families with mesothelioma that tends to cluster with uveal melanoma or indeed cutaneous melanoma for reasons previously that we didn't really quite understand. There's a whole bunch of other malignancies that can be seen. These are all underpinned by mutations in the BAP1 gene. So these are germline mutations. You're born with them. You inherit them either from your mum or your dad. You're born with them, and they significantly increase the risk of developing one of these diseases. Whilst it's quite rare, bizarrely, this familial syndrome has been called the common syndrome. I think it should be called the uncommon syndrome. But it's important that you have a feel for this, because if you do, then that sort of patient ought to see a genetic counsellor about some sort of gene testing and the risk to other familial members. Now, does it matter? Well, actually, it might matter. Because when the investigators, Michel Carbone and colleagues who discovered BAP1 germline mutations, looked at their outcomes of their families compared to SEER database outcomes of patients with bog standard meso, you've got a doubling of median survival. Now, these are small numbers of cases because it's not common, but actually there seems to be some sort of signal there that these patients have a different type of mesothelioma compared to what we are normally dealing with. So that's the germline inherited BAP1 mutations. We don't really know too much about these people who are born with this inherent risk of developing mesothelioma. However, you can develop BAP1 mutations in your tumour irregardless of whether you're born with a BAP1 mutation or not. In fact, if you do comprehensive molecular screening, which Michel's recently published in the JTO, you can find that 65% of your tumours have some sort of BAP1 abnormality, mutation, total gene loss, some sort of epigenetic change. So between NF2 and BAP1, you've pretty much got most of your mesotheliomas covered here in terms of a genetic abnormality. What does this mean? Well, BAP1 is involved with a whole bunch of processes, including DNA repair. BAP1 loss itself is not currently druggable. But there's a lot of people working on the downstream effects of BAP1 loss, and it certainly switches on alternative pathways to see whether they are druggable. And it wouldn't surprise me, again, if in a few years' time we're asking for a BAP1 IHC to see whether it's lost in your patient, to see whether that switches on another pathway, such as a DNA repair pathway. So, forgetting about genetic approach, what about the metabolic approach? Peter Schlosrick and the Bart's group have done some really good work, Peter specifically, looking at arginine depletion. You probably heard this story before, but mesotheliomas depend on arginine to grow. There's a small cohort of mesotheliomas which inherently have loss of the ASS gene in the way that they develop. If they've lost the ASS gene, they are absolutely critically dependent on receiving arginine extracellularly. And if you give them a drug called ADI-PEG, which switches off arginine entry into the cell, then those mesothelioma cells basically die. And so Peter's got this superb study where he's been giving patients, randomizing them to either ADI-PEG or best supportive care, and he presented the first cohort of this at Well Lung in Sydney and demonstrated that compared to doing nothing, best supportive care, giving ADI-PEG doubled the time to relapse. The compound has now been taken on by Polaris Pharma, which is the company is now entering into a large combination trial with chemotherapy, undoubtedly active in patients with ASS loss. So we've talked about metabolic processes, we've talked about genetic processes. What about what's going on the mesothelioma cell surface? Most of you have probably heard about mesothelin. It's a protein that's on the tumour cell surface, can be shed into the pleura, shed into the blood. It tends to occur on the epithelioid variant rather than the sarcomatoid variant. So wouldn't it make sense if you gave a drug which is a monoclonal antibody which bound to mesothelin on the tumour cell surface, and if you combine that antibody with a toxin, then you have your magic bullet? Right, it's not rocket science. Well, actually, it's quite difficult to technically achieve, but colleagues at the NCR, this is Rafit Hassan, have done this. So he's taken and developed an anti-mesothelin antibody, and he's conjugated this to a bacterial endotoxin called SS1P. And in this small phase 1 trial, he trialled this with a few patients and indeed demonstrated some very good tumour responses, initially with a lot of inflammation followed by long durable responses. Now the problem with this is that the body doesn't like seeing an endotoxin, so it mounts an immune response against the drug, and so you have to give immunosuppression. In this trial he was giving pentostatin and cyclophosphamide to deplete T and B cells. But what better immunosuppressant than cisplatin pemetrexed chemotherapy? So the next stage of development of this compound is to combine it with chemotherapy. This is his phase 1 data. There is phase 2 data as well, and this has already been run in the US. And you can see that you've got very good tumour shrinkage. And this is a single-arm study, but I would suggest that this is probably better tumour shrinkage than you would expect to see with chemotherapy alone. So this is being taken forward in a randomised trial as well, and maybe this is a very good way of augmenting the chemotherapy, which we know has some limited effect. But perhaps an immunotoxin is actually not the best compound to combine with an anti-mesothelin monoclonal, and Bayer know about this, so they've developed their drug called Anetumab ravtansine, which is basically a monoclonal which binds to mesothelin, bound by disulfide linker to good old-fashioned chemotherapy. This is DM4, which is basically a spindle poison. And so the idea is that you give this monoclonal antibody, it binds to your mesothelin-expressing cells, i.e. your mesothelioma, and localized delivers your cytotoxic there. And they're trialling it in mesothelin overexpressing tumours. That's not just mesothelioma, it's ovarian cancer and pancreatic cancer. They've got a phase 1 study, and they'll be publishing and presenting the toxicity data from this together with some limited efficacy data. But the data that they've released to investors rather than academics, because actually the pharma are all interested in fundraising, does demonstrate that some patients have got very good tumour shrinkage with this as monotherapy. So the question is, how good is the tumour shrinkage? What are the side effects? Do they actually justify? That will determine whether this gets taken forward. What about angiogenesis? So with you being, us oncologists, we like adding Avastin to every drug known to man and then presenting them to you to operate on afterwards. We've tried Avastin with mesothelioma with actually limited success so far. So this is a US study which Hedy Kindler presented, randomizing patients. They got gemcitabine and cisplatin and were randomized to receive either that with Avastin or that alone. And actually, it didn't make any difference whatsoever, which is surprising because actually, my surgical colleagues told me that mesothelioma is by and large quite bloody. And if you look at the expression of vascular growth factors, most mesotheliomas highly express vascular growth factors. So this was quite a surprising result. When the investigators went back to look at the bloods on the patients that they'd randomized, they demonstrated that those patients who had high levels of circulating vascular growth factors actually had a bit of a benefit. So in parallel with this study, the French have done a similar study called the MAPS study. They've used Avastin in combination with standard cisplatin pemetrexed. This study has been presented at ASCO in a few months' time. It's been granted a late-breaking abstract slot. I have no idea what the results are, but that makes it sound quite interesting. This was a two-step trial. They had to demonstrate a progression-free survival advantage for Avastin before the main study to demonstrate an overall survival advantage. The progression-free survival advantage was seen, and the main study was triggered, and we're hoping to see the overall survival data at ASCO. Irregardless of that, we've got ongoing trials of nintedanib, cediranib, and this TNF vascular disrupting agent. So the concept of switching off mesotheliomas to enhance chemotherapy through vascular disruption is certainly very exciting, and it wouldn't surprise me if one of these studies came through in the next few years or so. Right, so the big buzzword in oncology, if you ever speak to oncologists in the corridor, is immunotherapy. The Science magazine breakthrough molecule of the year 2013. So where are we with immunotherapy? What does it mean, and does this have a hope in hell in mesothelioma, or is it just a fad? So immunotherapy is very different to what we've been mucking around with as oncologists, targeted therapy, because with targeted therapy, what we're aiming for is something that's very active, switches off the cellular process, it causes a lot of tumour destruction, and what you do is you bring out the median survival. All patients develop resistance, so actually your long-term survival isn't any different. With immunotherapy, what you're doing is you're switching on the immune system, so you get no immune tolerance, and it may not work in a load of patients, but actually in those that it works, it has really quite significant, meaningful activity. And so what you're seeing is a change in shape of the Kaplan-Meier graph, and you see you don't really see a lot of differences in the median, but what you see is a big difference in the rate of long-term survivors. That's the big difference with immunotherapy. So what do we have with mesothelioma? Well, let's take the example of melanoma. Many of you operate on melanoma patients with their lung mets, I know. Well, in melanoma, we've now got very, very active therapies. This is the first of many active therapies. This is ipilumumab, which is a CTLA-4 inhibitor. This basically switches on your immune system, and you develop a whole load of autoimmune complications. And if you're not dead of your autoimmune colitis, you may survive long enough to have your benefit against your cancer. And this is what you're seeing with ipilimumab, which is the blue graph, compared to chemotherapy. You're not seeing much of a difference in the median, but you're seeing a doubling of the five-year survival rate from 8% to 18%. And the hope is that you'll see some sort of benefit with other tumours. So what have we got with mesothelioma? This is Tremelimumab, which is a similar compound being developed by AstraZeneca. This is a small Italian cohort of 29 patients, heavily pre-treated, who were treated with IPI. And only 2 patients had good evidence of good tumour shrinkage. That's not surprising because that's really what we're expecting to see with immunotherapy. But you had some patients with really quite prolonged stable disease. And if you look at the 2-year survival rate here, you've got a 2-year survival rate of around 40%, which I would say for a heavily pretreated population is quite surprising. Now, let me compare that to vinorelbine. So you know that your oncologist will generally use vinorelbine for the relapse setting. Well, vinorelbine's a pretty rubbish drug. We do use it, but we don't like using it. And the 2-year survival from this study, which is the data that everybody bases it on, is only 20%. So, you shouldn't really make cross-trial comparisons, but actually there might be something here in the immunotherapy story with mesothelioma. AstraZeneca certainly think there is, and they've invested billions in a randomized phase 3 trial, which is currently recruiting internationally, taking patients who've relapsed following chemotherapy and randomizing them to either Tremelimumab or placebo. Well, the new kid on the block is the other immunotherapeutic drug called nivolumab, anti-PD-1. This switches on your immune system through another set of mechanisms, but is really very well tolerated indeed. This is transforming lung cancer, and 1 month ago this was given an accelerated license in squamous cell carcinoma of the lung by the FDA. This data has not been presented in any scientific meeting or been published. It's just simply come out as the FDA license. And it shows a big improvement in survival compared to docetaxel, almost doubling. And again, the key here is in the tail. You're getting responses, not in many people, but in those that it do, you really do see very good survival. So for this drug to be active, by and large, you need to have your tumour expressing PD-1. So does this occur in mesothelioma? Well, this is data from my colleague Aaron Mansfield in the US, and he's demonstrated, yes, mesotheliomas do express PD-1, but they tend to be expressed on the poor prognosis sarcomatoid and biphasic variants rather than your epithelioid variants, and it's associated with a poor prognosis. So is this really true, or is this just a one-off series? Well, my colleague Enriqueta Felipe in Barcelona has recently published this series which confirm this. You do get some expression in the epithelioid subtype, but more so in the sarcomatoid subtype, and it's associated with a poor prognosis. So PD-1 expression is very much the way to go in immunotherapy, and these patients have been included in the large numbers of phase 1 trials of these drugs which are going through, and there will be data presented on efficacy of these drugs, which I suggest you look out for in the summer in the various oncology meetings coming through. So I'll close by saying that I agree, current drug options for mesothelioma are really quite limited. We've got the options that we have, which are not very good, but we need to improve on them. There are multiple drug trials open at an unprecedented rate, I would say, now, compared to where we were a few years ago. We've got a much better idea of the biology, and I think we're going to be following the adenocarcinoma story in lung cancer in about 5 to 10 years' time in mesothelioma to totally transform the way we treat these patients. And I can't finish without a plug for IMIG 2016 in Birmingham. Put it in your diary. It's going to be a good meeting. Thank you, and happy to take any questions.